Good morning. I'm very happy to be here. Thank you very, very much for the invitation, and thank you for letting me talk about this topic. Also, sharing the table with such dear friends is a pleasure. And well, today let's talk about the preventive interventions in different contexts. Right, we're going to talk about different components, different approaches. They are complementary in a way, and I was chosen to talk about the prevention of substance use during pregnancy. It's a short period in a woman's life, but it's also fundamental, not only for a woman's life, but for all our lives, right? So, to start, we often hear that, well, historically speaking, drug abuse has always been more common among males than females, right? And that has always guided research on drug abuse, prevention propositions, care lines, the education of us as professionals, the treatments. They have always been directed at males. Ever since we start prevention until the treatment of addicts, everything is designed for men, right? But and we talked about this yesterday. We talked about this today. The problem is that from an epidemiological point of view, substance abuse is a very dynamic thing, and the substance abuse among women has increased and changed over the last decade. So let me give you some examples, some comparisons between two studies, just to encourage our reflection. The first chart shows the smoking rates in Brazil, the decrease in smoking rates in Brazil. Brazil is a success case in smoking reductions, but then the reduction among women is smaller than among men. And on the side here, you see the binge drinking patterns, comparing data from 2012-26. This has increased globally, increased among males, but it increased even more among women. And again, here at the bottom, there's just particularly worrisome data talking about the early start. So the question was, among those who consume alcohol, at what age did they start drinking alcohol? And in 2006, it was up to 11 years. Only 1% of the girls had started before the age of 11. In 2012, this changed to 4%. And the rates among boys remained the same, 5%. Same for between 15 and 17 years for boys. For men, the rate was the same, 41%. And for women, it increased from 28 to 32%. This is also pretty recent data, the PACE research done specifically with teenagers in school settings. We cannot forget that we're dealing with teenagers who are going to school. And this is worrisome data, this comparison between use, trial of alcohol, the green line. You see that the rates among girls are higher than among boys, and the rates of smoking and use of illicit drugs is identical for both genders. This data can be found. It's the same, pretty much the same data, the same rates for every state in the country. This is very important information when we talk about substance abuse among women, either pregnant or not, which is the correlation between substance abuse and emotional problems, emotional suffering. This is particularly important when it comes to caring for women. This research shows that 18% of our teenagers between 13 and 17 years old indicated negative aspects of their mental health. And then when we split this between boys and girls, it was 8% among boys and 27% among girls. So the percentage of suffering is much higher among female respondents. Feeling over-concerned or sad or irritated, and especially feeling that life is not worth it, all these indicators are more prevalent among girls than boys. Here, another data from INAD that points to the correlation between depression and the use of psychoactive substances, including alcohol, marijuana, and cocaine. For all of them, when there's depression, these rates are substantially higher among women, which means that we cannot talk about treating women without considering aspects that are particularly related to psychic suffering. So a number of particularities among women require a specific approach, and we have to learn more about these particularities so that we can come up with oriented approaches, or approaches that are not oriented for men. So there's the role of women in the expected role of women in society, the stigma of substance use. So we have to consider the stigma, the expected role of women, psychological issues, like I just said, the importance of relationships, the clinical impact. We know that when women use substances at the same rate as men, they have earlier physical impacts. They get sick more severely and sooner, and there are also psychiatric comorbidities that I just mentioned. And a very particular aspect when we talk about the substance use among women involves their reproductive health, which is the focus of my talk. In Western countries, the estimated prevalence of unplanned pregnancies at about between 30 to 50%. The use of substances is associated with higher chances of unplanned pregnancies, or worse, undesired pregnancy, because it may not be planned but then become desired. But when it's unplanned and undesired, this relationship causes even more suffering for women. And 90% of substance users are in reproductive age. So this is very important data for us.
Women who are substance users tend to use less frequently the healthcare services. Why? There's prejudice, they have difficulties to discuss their sexual life. They comply less with treatments, and many times they are afraid of talking about substance use and lose their child. On the other side, when the service is accessible, qualified, there are motivations, and women make choices that improve family planning. So we have to create treatments that focus on this. So when we think about pregnancy and related with mental disorders and substance use, we have to think that for most women, having a baby is a happy moment. It's related to positive aspects. So pregnancy is something that might encourage women to decrease substance use. However, pregnancy is seen as from a romantic point of view. Pregnancy doesn't prevent women from having mental disorders or from being more depressive. The study shows that one out of every 3 women, they suffer from some sort of mental disorder during pregnancy. And after birth depression are actually depression that took place during pregnancy and were not treated. We know that less than 20% of mental disorders during pregnancy are not taken care of. If there's a stigma related with women who use substances, the stigma increases a lot when it's pregnant women using substances. So there's prejudice from society and even healthcare professionals. So it increases the chances of not informing doctors that they're using drugs. If they don't inform doctors, they are not going to be informed about the risks associated with consumption. Or sometimes when they do talk about it, they are not. They don't say everything. Another aspect that has been historically problematic is studying the impact of substance use during pregnancy. The first reason why it's due to ethical reasons. We cannot ask pregnant women to use substances. What we have are relational studies. And there's a lot of under notification. We have to know if pregnant women used drugs. Multiple consumption also is something that affects negatively, and then lifestyle. We don't know, miscarriage or a baby that was born too small, was it related with drug abuse, drug use, or lack of proper care? So it's really difficult to talk about the real damage, drug use during pregnancy can cause. But we have tons of information about it, and we have to inform pregnant women in that correctly. So with relation to tobacco, I'm just showing you the most common problems. So spontaneous miscarriage, lower growth inside the womb, and increase in the likelihood of sudden death, and children are more likely to develop mental disorder. With regards to alcohol, we do have a lot of information. So there are different malformations. The most common one is the fetal alcoholic syndrome, which is something very severe, and it is the main cause for intellectual impairment. And sometimes the babies don't have all of the symptoms, but they will have their cognition affected. With regards to cocaine, there is information, but hardly ever a pregnant woman who uses cocaine alone. It's difficult to isolate specific consequences caused by cocaine. So here we separated alterations during pregnancy, fetal malformation, and consequences in the newborn, especially high levels of activity. With regards to marijuana, the number of research studies increased a lot. Today, since there has been an increase in the consumption of marijuana, there is an increase in the number of women who only use marijuana. I coordinate a program, and frequently the pregnant women, they say, I don't use any drugs, just maconha. It's natural. So nowadays, it's easier for us to observe the effects of marijuana isolatedly. And there's an interesting study that evaluated babies from inside the womb and until they were older. So the current recommendation is that marijuana should not be used during pregnancy or while breastfeeding. So it is not recommended during pregnancy and while breastfeeding. And there are other aspects that can aggravate these problems: psychiatrist comorbidities, bad evolution of previous pregnancies, non-planned or undesired pregnancy, sexual violence, domestic violence. So these aspects, they aggravate bad outcomes in pregnancies. So these contexts, they are frequently associated with drug use. And we have been conducting a segmented study. We stopped during the pandemic, but now it's on again. So we evaluated pregnant women during pregnancy and after birth. What we saw was 41% of anxiety, 31% depression, and 9.5% of suicidal ideation. So the women who are there, they have some sort of problem in their pregnancy apart from substance use. So the number of women who smoked were 9.3%, 5.3 used marijuana, and 5.3 used alcohol. It's too many women. And this study showed a very interesting piece of data. Many pregnant women stopped spontaneously the use of those drugs when they got to when they discovered they were pregnant. Many women stopped spontaneously. And this last column is the women that were not able to stop. But it was we conducted a policy of awareness, and it was quite successful. We created these leaflets, and we talked to them about the risks involved for the baby and for them. And what we observed was that when we asked them, do you know that using this substance can cause risks to your child? All of them would say yes. And when we asked, do you know which is the risk? Most of them didn't know. So one thing is having a generic idea that it's not good to your health, but and another thing is knowing the real facts, you know. Sometimes they would say, oh, when I had my other baby, my baby was okay. So when you give data that makes sense to them, motivation increases. And after this initiative, there was a lot of success in the reduction of alcohol and marijuana. With tobacco, there was a reduction in pattern, but not a reduction in the number of smokers. This is a very practical article. It talks about the importance of asking about the use of the substance use for those who are planning to get pregnant. So we offer support before, and the study suggests some questions to be included during prenatal care. What are the substances you're using? What is the use standard? If your partner or someone else in your family uses it as well, if they are aware of the consequences, if they are going and having prenatal care, and if they intend to breastfeed. And the idea is to add to these questions motivational intentions. If we ask them about the risks, we can give them information. If they have a thought about reducing consumption, we can talk about the barriers and how she can get help. So we always encourage women and say that they are capable of changing. What we need is to break the stigma in relation to the use of substance use among women, especially pregnant women, because this makes them avoid seeking treatment. And if the women are not there, the services are not being adequate for them. And then if the service is not adequate, there's no compliance and then it's a cycle that will never end. So we have to break this perception, the stigma among women, and especially among pregnant women. When they are pregnant, we only have a few months to intervene. Now, key aspects, strategies with regards to healthcare are central. Prevention strategies directed specifically at women are extremely important. We have to focus the needs of the mother and the baby, because this will encourage women to reduce use. We also have to talk about the partners and other family members, look for domestic violence. We have to identify comorbidities. And we have to remember that mothers' mental health, a good mental health of a good mental health of mothers is central for the development of their children. Thank you for sharing so much good information with us. Now I would like to invite Dr. Cecília Marques, and she is a psychiatrist and member of the advisory board of ABEAD. Good morning. I would like to thank Fremont organizers for having invited me. ABEAD was invited to take part in the event. It's a Brazilian association that was created 45 years ago, and our institution focuses on science and pragmatism. We use science to build our history. There's no use in bringing imported models. Brazilians are known for their creativity, so studying, we are going to become even more creative. We are going to have the good pillars that are going to enable us to build policies and interventions. Renata was talking all the time about prevention. We need to create preventive initiatives, because after use starts, we will have to address the consequences. And sometimes the use becomes a snowball, which is disorders related as a consequence of substance use. And I would like to thank Alessandra, President of ABEAD, for having invited me. We need to evolve to a type of prevention that is modern. So I have no interest conflicts. I am retired, but I keep on working a lot for the collectivity. My main mission is to create and work on products that make a difference for Brazilian people. This slide is wonderful and nobody has to read it. And it's here to tell you that risk is everywhere. There is risk in every stage of human development. The name of my talk is risk factor, maybe modifiable risk factor, because human beings face adverse situations all the time. Sometimes these things will change their lives, and drugs is one of these factor. we know that substances interfere in a human being, in all the cells of the human beings, okay? So planning pregnancy is important. They have to see the doctor to get information about how to do it. So SUS, our primary care services, offer alternatives. And what else contributes to an increase in risk factors? You know, being a woman is a risk factor for substance use. Gender, there's no way out. We thought that it was a man's thing, but women are the ones who are impacted the most. And it impacts not the child that is being generated and the family and other people, members of the family. Because why? Because women are those who are responsible for the development of families. But if they make substance use during pregnancy, there will be problems. You know, the grandmother will have to take care of the kids because the mother might fall ill, so on and so forth. So risk factors are present in every stage of a human being's life. But we can change the impacts if we work with prevention. But prevention has to go way beyond science. Science of prevention has a history, and we've seen many different models over time. But I think we have to be courageous and think about new alternatives. Risk factors during teenagerhood. Well, we've all heard about it, the power of the group, the family that cannot set limits. Teenagerhood is the most wonderful moment of our lives and is the moment in which our health is at its best, but it's the moment in which we are extremely close to risk. Sometimes children, for example, they have 5 types of vapes, like we saw in the picture. Ladies and gentlemen, we know that prevention starts at home. It starts within families. Children have the right to be protected. They do not make decisions. They rely 100% on an adult, be them a father, a mother, or a grandmother. And it's really, really difficult to work with prevention, but we have to understand that it starts way before a woman gets pregnant. And we are going to learn about risk factors in children who are under 3 years old. And we have to talk to the parents. There's no way out. You think that, children or youths, like a 7-year-old child, will believe the teacher and not believe her mother or father. Let the teacher teach. Prevention starts at home, and no one is better than a father or a mother. They are the best prevention agents. I think this is where our history is. So we have to try and evolve and create new models. We have to act in a different way. And if we don't do things, the fetus, the child, the small baby is going to pay for it. Teenagers, they know much more than us. They buy all sorts of drugs. The mother of my patient sent me a picture, and they have a menu of substances. They send the pictures to us. They cannot keep up with it. They are not able. So, modern prevention has to do with detecting. People do suffer throughout their lives, but parents are the greatest influencers. Risk zero does not exist, right? So human beings are there is risk everywhere. Did you see the big industry? They create the most interesting campaigns to sell tobacco, and we have no money to invest on research studies. So we need to focus on how we're going to tackle the problem. When I talk about social and environmental aspects, I talk about parents who have no bonds with their children, parents who have no schooling, parents who are violent. You know, if a parent is not literate, they cannot cope with what we say. You know, who reads scientific articles? If the person didn't have proper schooling, it's gonna be different. So we have to help families deal with lack of things. This is modern prevention, and because young people will keep on trying things. I haven't forgotten my teenagehood. In order to deal with teenagers, we have to remind our when we were teenagers, and think how marvelous it was. I was a person who wanted to evolve, and everything that my mom or father would tell me, I was against it. Now, unfathomable factors. What is written down in red, these ones. So what is the factors that were written down in red in the previous slide? There are at least 4 risk factors. Do we have a pointer? No, we don't have a pointer. So those 4 factors. Okay, let's move on. No problem, no pointer. So those 4 risk factors that I consider the most important ones, like mental disorder in the mother, everything that Renata talked about before getting pregnant, and it says how it, they need parental guiding, family planning, or if it doesn't work, if they have severe mental disorders, we can refer them for treatment because people are in suffering. So refer patients to other professionals, refer them to specialized care. But you don't just refer the patient. You have to check if the patient really did go. We have to ask patients if they smoke, if they drink, if they use any type of substance to all individuals. Once we are screening patients, we have to ask this. Community agents, they have to ask about this. And usually the agents don't ask about it because they're shy. So the teams have to be trained because our allies are the healthcare community agents. They influence much more than doctors. So prevention is central. And we have to check which are the needs. So female gender, as I told you, well, for that, we would have to create a new type of policy only for women. Renata also talked about it, and I think that Alessandra will also talk about it. So let's move on. Look how simple it is. Individual psychological risk factors. It's just solve it with psychosocial intervention. Where do we get it from? From the primary care? No. Where? I have 5 minutes. At SUA, unique system of social assistance. If there's a child that's being neglected and suffering violence, we have to talk to all of the departments. So we need a female policy based on gender and intersectorial approach. We need to remember that there are all other sectors. Look how beautiful this is. And we need prevention based on a system. An example of system is the family. The family that receives care will invite another family that will invite another family, and that will invite another family, and then we will start to see change. Psychosocial intervention, parental guidance. We have laws that define drug policies. I am so old that I helped to write this policy down. Half of the policy is not enforced. Why is that? Because politics is far from science, and our country is the size of a continent, and we are not integrated. If there's no integration, intersectoriality, policies will never be successful. And I think that this is something that all of us already know. Should we audit politics? Yes, we are going to say that it's forbidden to advertise drugs. We know about the power of those substances. We don't want the body of women being used to help selling drugs. So look how curious. In 1960, the World Healthcare Organization, how do we do prevention? It's based on a model of quality of life, which is the right of every human being. Um, I am an elderly woman, and uh, I also have this right. And I hope that I have the hope that if we work as a group, we will be able to work with prevention. Thank you very much.
Thank you, doctor. Prevention is our motto here. We know the importance of this type of initiative, and we work to bring families and science together for the benefit of everyone. Dr. Alessandra Diehl, psychiatrist, she's going to talk to us about cannabis and schizophrenia. Cannabis use and schizophrenia. Thank you for the opportunity. Thank you for having me here today. I'm very happy to be a part of this session, and my special thanks to ABEAD for hosting this panel and for inviting me to share the table with colleagues and friends. I'm very proud to be here with you ladies. I am very proud to be part of this girls group here, and it's an honor for me. The previous speakers have already made a case of the importance of gender for this. I was thinking about Beyonce's song, Who Runs the World. I am positive that it's us. We women run the world. Sorry, boys. Sorry, gentlemen, but that's the truth. What are you saying? Remember that I run the world. Okay, Sabrina. Sabrina's going to help me with technology. All right, so with development psychiatry, within this context, it is up to me to talk about the relationship between cannabis use and schizophrenia. Today, there's plenty of evidence that schizophrenia is a disorder of the neural development. What does that mean? Well, it means that there are some factors that if they occur during pregnancy or childhood, my colleagues just talked about that. But there are some things that if certain things happen during these periods, they will have consequences in social skills, in communication skills of the individuals in the future. Schizophrenia is one of those disorders that it has an impact on social skills, communication, and ultimately it produces some substantial deficits, and actually it affects 1% of the population. Schizophrenia is a chronic progressive disease, and even though we have some excellent medication for it today, much better than when I started my career 20 years ago, there are also other psychosocial interventions better than in the past. Many of these patients will progress to a very severe form of this disease, which we usually call early dementia. And the causes of schizophrenia are not fully understood. But we know there are some etiopatogenic factors that are involved in the onset of this disease and its progression. There's this genetic inheritance, meaning family history. If you have schizophrenic people in your family, your likelihood to be schizophrenic is also increased. Other factors like living in urban areas, abuse in childhood, mistreatment, being part of an ethnic minority. These things also affect your risks of developing schizophrenia. And of all the psychoactive substances that we know, marijuana is the one we have most evidence about. We have the most evidence of the correlation between marijuana and schizophrenia. It appears in a period that we call pre-morbid, or meaning that the start of use of marijuana frequently coincides with the onset of the schizophrenic symptoms, the first psychotic. And this with delusion and things like that. So, and this can be confusing because sometimes we think it's a normal thing in adolescence, because adolescents tend to be sometimes more, that sometimes adolescents keep to themselves, and our teenagers today spend hours and hours in their bedrooms, and sometimes parents fail to notice that. But sometimes it's a combination of these two things. It's marijuana use, cannabis use, and that can lead to a psychotic condition. I believe that you heard my colleagues say or talk about this coincides with the premorbid period of schizophrenia, and this occurs in a brain that is still in formation. It's developing. Some people say that our brain only fully matures at the age of 25. So people often start using cannabis when your brain is not ready yet, when it's not fine-tuned yet. It's still going through the neuron trimming process. It's a process where our body gets rid of no longer useful for us, and pruning. So this synaptic pruning is extremely important for us to reorganize our transmission of information in our brain. So this shows us the importance of, or how serious it can be, how problematic it can be to use a substance when our brain is going through this process, how it can even impair the development of our brain. According to the World Drug Report today, there's 200 million cannabis users, or people who used cannabis in the last year of this research. And of course, this high number of people doing this drug makes us think that it's the most popular drug worldwide after tobacco and alcohol. And the risks of consuming this substance are attracting increasing attention from researchers, and the association between schizophrenia and marijuana is also attracting more and more attention. In Brazil, our surveys show a prevalence of about 7.7 throughout life, 2.5 in a year, which is not actually very low as it may seem. And especially what concerns us about cannabis use is data that comes from the US. This beautiful study that ABEAD has been monitoring for many years. It's called Monitoring the Future. It's a study that's been conducted since 1975 with American school children. It's a very representative sample, and every year systematically they ask the same things, and they have recently added questions about vaping, marijuana vaping, and among other things, they show when you ask teenagers whether or not they think marijuana can cause any problem, the curves clearly go down. And on the other hand, the use increases systematically, especially the red curve, which shows longer series. And this is not an accident. This is the product of what my tobacco colleagues said. The same theory applies to the use of cannabis. So this perception of low risk on one hand, and marijuana becoming increasingly more powerful on the other hand, is a hazardous combination. The level of THC is now 4 times higher than in the 1990s, and 10 times higher than in the 1970s. So we're not talking about just any other product. Marijuana is not a commodity, as they want us to believe. So, and undoing this cultural input takes time, and we are definitely running behind schedule. Marijuana is also associated with psychiatric disorders. There's plenty of evidence of that. There's this researcher called Robin Murray from King's College. It's already the second edition of this book. He talks about marijuana and madness. It's a popular book that shows, among other things, that the rates of psychiatric disorder prevalence are higher among those who smoke marijuana. And this association seems to show a clear interaction between individual factors, meaning your genetics, for example, and the effect of this substance. So cannabis has been pointed as a risk factor for the development of schizophrenia in 6% of the heavy users of this substance. I said heavy users between quotes because for many years we thought, well, some still believe that, but still, the evidence supports that there is a dose effect relationship, but some said that maybe the experimental usage wouldn't be that risky, but that's a problematic conclusion. There's another mental disorder here that is associated with marijuana, and there are also studies showing this correlation. Because even though you may use cannabis, it may increase your chances of developing other disorders by 1.02. If you abuse this substance, your chances increase twice. The chances of having another disorder increase by 2 times. And if you have another disorder, chances increase 5-fold. So this gives us some important information. It tells us that the pattern matters and that there's a high prevalence of comorbidities in the patients we treat. Association or chance? Does marijuana really cause schizophrenia? Is there a causal effect here? That's a challenge for science. We don't know exactly how it happens, but we are sure that marijuana can be associated with the start of this serious condition, which is schizophrenia. And we've been talking about this for over 50 years. However, the nature of this relationship still deserves some attention. We do not yet fully understand this relationship, and that's why I put the link here. Go to our blog and read this paper. It's actually, it's not really an article, it's a summary that gives you a lot of information between this relationship of marijuana and schizophrenia. Our Nigerian professor told us today, like applying scientific research to our life, to our practice, to our everyday work. For those who do not read papers and scientific articles, right? That's extremely important. Dr. Anna has just shown us some family-related data, and these data tell us that the more we know the environmental factors that are at the origin of schizophrenia, the more tools we'll have to fight it, the more tools we'll have to prevent the start of this disease or maybe the worsening of this condition in patients who already have it. And you see, among all the environmental factors, by far, marijuana is the one with the highest ratio of leading to schizophrenia. This is a fairly recent article from 2019, and it shows that the use of marijuana increases the chances of developing schizophrenia by 5 times, more than childhood trauma, more than migration, which is another interesting factor. I studied the Japanese migration from my hometown back to Japan. They came back from Japan with high levels of psychosis. So because you migrate to another country and you don't speak the language, you don't belong in there, and marijuana is worse than that. The ratio for marijuana is even higher. Additionally, we also know that some genetic combinations in particular, like this allele at the edge here with the O transferase column, if you're if you're a bearer of valin, your chances also increase by twice. Your chances of having schizophrenia also increase if you have this combination of genes. Other studies corroborate the impact of schizophrenia in the development of psychotic symptoms and schizophrenia. There's this paper by Adriana Marconi, which shows the increase in psychotic episodes after the consumption of marijuana, and there are also some other studies from prospective sources. Because so far, because many studies did not have any follow-up to control other factors, but one of those studies comes from this review. It's a review of 7 studies from European countries like Germany, Sweden, the Netherlands, also Australia, New Zealand, with 50,000 individuals. It's a very significant cohort that shows that marijuana is a risk factor for the development of schizophrenia. So we know that most of these studies are being conducted in European countries with countries like of white people, studies with many males. But and so the criticism I make is, what about Latin America? How do we do this in South America? We're mixed race. What should we do? Shouldn't we include more women? But then we need funds to do research. It takes money. So in Latin America, we can be very creative, like she said, but there's only so much you can do if we need money to actually have a good follow-up. Marconi's study also shows that the start of schizophrenia decreased, or the start is 2 to 6 years earlier if they use marijuana, which means that the earlier the psychotic symptoms appear, the more severe the schizophrenia will be. So let's say you have your first psychotic breakdown at the age of 25 or 26 or 30, your prognosis is better than if you have your first breakdown as an adolescent, as a teenager. And this also, the risk for psychosis increases when you start doing marijuana at a younger age. I'm still getting familiar with the clicker, so bear with me. Another beautiful study that I'm very fond of is this one that worked with a cohort of 30,000 Swedish soldiers. They were followed up for 35 years. Can you think of a 35-year research project? I'm amazed at this project. They worked with these patients for 35 years, and this study gives us evidence that those who used marijuana were 3.7 times more likely to have schizophrenia and other types of psychotic diseases. This is a very beautiful study. Other studies with smaller samples also sustain that. They also have an odds ratio. This shows the odds ratio for some other studies, maybe not as significant as the others, but when we put all these studies together, they clearly show us that it's at least twice the likelihood, right? And then you may ask me, oh, what if there are some cases that we call the cannabis-induced psychosis. We don't really know whether that is schizophrenia or not, right? Before the diagnosis of schizophrenia. And then that's about 47% of the sample evolved into schizophrenia or some sort of bipolar disorder, which is not an easy condition. So it increases every risk you can think of, especially among teenagers. Of course, there's a relationship between the symptoms and the development of the disease and the frequency of use, but that's not all. There are some other factors like parental risk, meaning genetics. Statistics sometimes can show us that, but still, even if we could control genetic factors, marijuana would continue to be a risk factor. If you were to take a picture of my slides, this is the one, because this is the slide that shows that marijuana does increase the risk of psychotic diseases and schizophrenia. There is a clear relationship between dose and effect in the use of cannabis. We still have to learn more about that, but there is a relationship, and the more vulnerable you are, and if you're a teenager, you're naturally vulnerable, and if you have a history of schizophrenia in your family, or if you've already had a previous psychotic symptom, your chances of developing this disease also increase. And I'm telling you this because this is important from the psychiatric point of view, from the developmental psychiatry point of view, which considers the contributing factors for the development of such serious conditions. And this is key for us to take action and carry out effective prevention initiatives to actually and even prevent the worsening of this disease, which has a not very favorable prognosis, right? And it's also a disease that we do not fully understand. We're still struggling with with the right approaches. Early intervention is extremely important. And before I finish, I would like to invite you to visit our website. And we're also certifying professionals. Our certification program is open for subscriptions. So if you're a psychologist, an occupational therapist, a counselor, or any other healthcare professional without this ABEAD professional certification, go to our website, read the terms and conditions. You have to become a member first, but then you can have the certification. You need to have at least 5 years of experience in this area. But this certification is more than a seal, a stamp for professionals. It helps prepare you, and it recognizes the work you do as a professional, and it gives you the credentials to perform, to work better, to perform your practice in a more qualified way. Thank you. Thank you, Alexandra. Again, registrations are open until August 21st. Make sure you like us on social media. Make sure you follow us there. Again, I'm proud to be a member of ABEAD. I'm sure you will like it too. So make sure you check it out. Can we open for questions? Do we have some time for Q&A? Again, warm hands for this table. Big round of applause. I always ask the speakers to leave, but hang around and stay there for a few minutes because we may have some more questions from the audience. Some people are just too shy to get the microphone, So make sure you can be available a few more minutes. Please be a few more minutes. And I hope to see you again next year. Sure, thank you.